Thank you, Charles. And welcome, everybody. Thank you all for coming. It gives me great pleasure to introduce our first speaker, Dr. McKee. Her research over the past decade has led the field in CTE and post-traumatic neurodegeneration, and she's been instrumental in changing public awareness regarding the late effects of concussion, subconcussion, as well as blast-related injury. Her work has been fundamental to defining the neuropathological diagnostic criteria, staging scheme, and clinical pathological correlations of CTE. She was the first to report the association between ALS and CTE. She reported the first case of CTE in ice hockey, soccer, mixed martial arts, baseball, high school football, college football. She reported the youngest athlete ever diagnosed with CTE at 17 years old. And her team has defined the roles of other pathological proteins, TDP43, beta amyloid, alpha-synuclein, in the development and progression of CTE. Her team reported the association between high cognitive reserve and delayed emergence of clinical symptoms in CTE, and the association between age at first exposure to football and risk of cognitive impairment and depression in later life. Her team published on the roles of microglia and inflammation in repetitive head impact injury in CTE, the unique finding of cytokine CCL11 in CTE, on prion spread of tau in CTE, and the presence of prion disease in some individuals diagnosed with CTE. She's helped define microvascular injury and neuropathology of aging and Alzheimer's disease through her work with the Boston University Alzheimer's Disease Center and Framingham Heart Study. And we're so pleased that she's here. Welcome. And I think somebody will get her onto the screen. Thank you. Okay.
Okay, can you hear me?
Not very well.
No.
Yeah.
Okay, can you hear me better now?
Yes, we can. Thank you.
Is that loud? Too loud?
No, it's perfect.
Okay, great. Well, thank you so much for inviting me to share my work, our work at Boston University and the VA in Boston about CTE. I'm very sorry I'm not there in person. I really get a lot out of these conferences and talking to people in person, but unfortunately I'm remote or virtual today. I'm going to talk about our work about CTE and just to establish things, I have no disclosures. When I first, I think something you should know about me is that I grew up right outside of Green Bay, Wisconsin, which is well known for the Green Bay Packers. I was an enormous football fan. I was born and lived in the Lombardi era with the Super Bowl I and II. It was clearly the biggest thing happening in my very small town. My dad played football. My brothers played football. I was encouraged to play football, and I'm sure I would have if I hadn't been born a female. So this is my perspective that I came into this work with. I adored football, but the work has clearly made some changes in my attitude. I'm going to talk about CTE, which is a neurodegenerative tauopathy associated with exposure to repetitive head impacts. And importantly, that includes not just symptomatic concussion, but the much more frequent asymptomatic, what we now call non-concussive injuries. And just because they don't rise to the level of symptoms, these are not actually more minor injuries. In fact, the magnitude of the impacts in many cases can be as greater as those impacts that cause concussion. For reasons we don't entirely know, it's not just the velocity of the hit that gives rise to concussion. And there are many, many more asymptomatic hits experienced. And so it's the sum total of all of these head impacts that gives rise to the risk for CTE. As you know, CTE has been diagnosed in American football, ice hockey, soccer, boxers, wrestlers, individuals exposed to interpersonal violence, headbanging, military. And one of the biggest stumbling blocks for research is that the diagnosis can only be made after death. It can't be made during life, but that is clearly one of our major objectives in our research. And to clarify things, CTE is a pathology. The clinical condition associated with CTE pathology is called traumatic encephalopathy syndrome. It was first described nearly 100 years ago clinically by a pathologist named Harrison Martland. It went by a variety of names: dementia pugilistica, punch drunk. Critchley suggested chronic traumatic encephalopathy, and that is the term that's in widest use today. The first pathologic series was in 1973 in boxers, and that series described neurofibrillary tangles in the brains. But that series was limited by the techniques that were available at the time, largely a silver stain for the detection of neurofibrillary tangles. I think a very important study that was in the 1990s is this study by Patrick Hoff looking at an autistic woman who was a headbanger, and he noted this very peculiar accumulation of tau around blood vessels in her temporal lobe with no beta amyloid. And this was really the first description of the perivascular nature of this pathology. And this was seconded by Geddes et al., who described the pathology of 5 young men, 3 of whom were contact sports players, 1 epileptic, 1 headbanger. And this was the first time tau immunohistochemistry was used. But they showed too this very unique constellation of tau around small blood vessels in the brain. And of course, that has become one of the distinguishing features of this disease. My first case was in 2003. It was a boxer named Paul Pender, very well known in the New England area. He was thought to have Alzheimer's disease clinically, but when we got the brain in our Alzheimer's center, he had the most extraordinary tau pathology I'd ever seen. I had been very fascinated by tau for many years, and then to see this pathology, I was really taken aback. I'd never seen anything like it. The way it circled around blood vessels and hung to the crevices of the brain, and there was no beta amyloid. So it was clearly not Alzheimer's. And this is what started my fascination with CTE. Several years after this, Bennett Omalu and colleagues at Pittsburgh described CTE, an American football player. The first was Mike Webster. The pathology they described was relatively nonspecific, so I was not convinced it was the same thing that I was seeing in the boxers. But over time, we've learned that this is a bona fide case of CTE, as was the next one. Terry Owens, I believe his name was. I might have gotten that wrong. My next cases of CTE were in 2 football players, and this was because of my collaboration with Chris Nowinski and the Concussion Legacy Foundation. He wanted me to look at football players. I was delighted to do so for many reasons, not just the brain pathology, but I was a huge football fan. I was concerned about football. These were my first 2 cases, both 45 years old, both played 9 years in the NFL, both retired at age 32, but had some sort of non-specific symptoms that the wives had noticed, problems with memory, problems with multitasking. For Tom McHale, he became addicted to painkillers, which was quite unlike him. And for John Grimsley, he couldn't remember things from 1 hour to the next. Both died accidentally. And in their brains, I saw this extraordinary tau pathology. It was florid pathology, which was shocking to me because of their age, 45. I'd never seen such pronounced neurodegeneration in such young people. And it had all the hallmarks that I'd seen of perivascular deposition, accentuation in the cortical sulci that we'd seen in the boxer. So that was the reason back in 2008, we set up a brain bank to really try to understand the long-term effects of repetitive head impacts and traumatic brain injury. We started out very slowly, getting maybe 6 cases the first year, but over time it's accelerated considerably, and now we're working on 1,400 brain donations. Just to give you an idea what this looks like, you can see we started out slowly. It was really our JAMA publication in 2017 that brought wide awareness to the brain bank. We get calls primarily from families. Our second greatest pool of donations is medical examiners that refer families to us. And we do, through Concussion Legacy, do contact players in the minority. About 5% of the cases are through active contact with next of kin. This is the pathognomonic lesion of CTE. This has been described by 2 consensus conferences of experts convened by the NINDS and NIBIB. It was a group of 13 or so pathologists who looked at a number of cases and defined the lesion that we call the CTE lesion, a lesion that's not found in any other tauopathy or any other disorder. And the presence of a single lesion is now deemed diagnostic of CTE. So the lesion consists of tau, seen here in red. It surrounds a small blood vessel, and it's typically found at the crevice of the brain, what we call the depth of the cortical sulcus. You can see it here, here, and here. This is with tau immunostaining showing tau in this perivascular depth of sulcus distribution. So again, the diagnostic features are perivascular accumulation of tau in neurons, and this accumulation with a preference for the crevices of the cortical sulci. Back in 2013, we developed a staging scheme for evaluating pathologic severity, stage 1 through 4. In stage 1, you'll notice it's a focal disease, just a few isolated lesions in the cortex. Those lesions are still restricted to the cortex in stage 2, but are more numerous and affect more parts of the brain, more of the cortical lobes. By stage 3, it's becoming a much more widespread disease. We start to see spread to the basal ganglia, more spread to the brainstem, and also, very importantly, involvement of the medial temporal lobes. And in stage 4, it just becomes more widespread, more severe, affecting cerebellum and spinal cord. We found, even in that early publication, that the staging of the severity of the pathology correlated not only with the age at death of the donor, with the older players getting stages 3 and 4, and the younger donors more often stage 1 and 2, but it also importantly correlated with the number of years of playing football. And we use, and you'll see repeatedly in our studies that we use number of years of football play, and that's at all levels, as a proxy or an estimate of how many repetitive head impacts the individual has experienced. The PATH staging scheme was validated a few years ago. We looked at 366 individuals that had been diagnosed with CTE. We did quantitative tau assessments. We did semi-quantitative tau assessments. And we found that those correlated with the stage. We found age at death and dementia status also correlated with stage of CTE. And again, the years of American football play, a proxy for RHI, early indications that there was a dose relationship between exposure to head impacts and the development of CTE. Back in 2019, our research was considerably enhanced by the work of Michel Goder and colleagues looking at the filament in tau. As you know, there's a lot of similarities between the tau in Alzheimer's disease and CTE tau, but this was really the first demonstration that CTE tau is unique. It has a unique ultrastructural fold, and inside the fold is a hydrophobic molecule. The nature of that still is undiscovered, but it's very distinct from Alzheimer's disease. John Cherry in our group has done a number of studies on the nature of the tau pathology. It's a mixed 3R, 4R tau. In early CTE, it is primarily 4R tau. So in young individuals, it's 4R, and it's almost always, and I actually would say it's in neurons exclusively. We don't see any astrocytes in the early lesions in young people. As the disease becomes more severe, there's a shift towards greater 3R tau in the lesion. For our astrocytes, the astrocytes in the CTE lesion are always 4R tau. They increase as a function of age, not CTE severity. So if you're looking at CTE in older individuals, it's very common to see an astrocytic component to the CTE lesion. We know that tau is deposited in these regions around blood vessels and in the crevices because of the mechanics of the injury. The stress and strain concentration during impact injury is greatest around blood vessels and in the crevices of the brain, and that's exactly where we see the tau protein accumulate. This has also been shown in computational 3D and finite element models of helmeted head impact injury. These have been done in various institutions in England as well as in the US, and these computational models accurately predict the location of tau in the crevices of the cortex in the frontal and temporal lobe, as well as around blood vessels and in the crevices of the brain. Recently, there was a study in musk oxen, which is a gyrencephalic mammal. Their brain has gyri, just like the human brain. They participate in headbutting, and Patrick Hoff and Nicole Ackermans were able to show that in the musk oxen, of which they had 3 to evaluate, some of their brains showed tau pathology in a pattern and distribution that was similar to CTE in that it was neuronal and it affected the crevices of the brain more than the gyral crests, and occasionally it was found around blood vessels. There is to date no rodent model that can produce CTE pathology, that is the perivascular depths of sulci pathology, and that's largely because the rodent brain is lissencephalic. It doesn't have gyri, but I think also just constitutionally the molecular composition, the tau protein of a rodent may not be similar enough to a human to ever be able to get an adequate rodent model of CTE. And clearly musk oxen, that would not be an animal we'd want to do experimental studies in, but it is a demonstration that we can see similar pathology in other species. Some things I want to emphasize about CTE, I've talked a lot about the tau pathology, but in addition to tau, it's very important the inflammation that occurs in this disease. Not only is the CTE lesion itself inflammatory, that is, it has lots of microglia, activated microglia within the lesion, but we see a significant increase in activated microglia generally in individuals who are exposed to RHI. So if we look at a cohort of RHI exposed versus non-RHI exposed, we see a significant increase in inflammatory microglia in those exposed to RHI. So it's an early change. It's also significantly increased in CTE, and that increase parallels the severity of the CTE. So that gives rise to this diagram where years of exposure promote neuroinflammation. Neuroinflammation itself promotes tau pathology. Years of exposure also promotes tau pathology, and it sets up this sort of non-trauma feedback loop where once you have neuroinflammation promoting tau pathology further promotes neuroinflammation, and it's definitely one of the ways to explain the progressive nature of the disease, that there is progressive neuroinflammation and progressive tau pathology. There's been a lot of studies on inflammation in CTE. I'm not going to go through them, but we know that cytokines like CCL11, CCL2 are increased in CTE, and they're not increased in Alzheimer's disease and other disorders. We know that a variation in TMEM106B is a risk allele for CTE. In this case, it's actually a resilience factor. individuals with TMEM106B show less inflammation and less tau pathology compared to individuals without this allele. We also know that there's a differential gene expression in the sulcus where the lesions are compared to the gyral crest. We know that the cytokines that are increased in CTE differ from those in Alzheimer's disease and the other tauopathies like PSP and AGD. And we've also found recently that inflammation and neuronal gene expression differ in the early stages of CTE, stages 1 and 2, versus that much more widespread severe pathology that we find in late stage CTE. We know there are microvascular changes in CTE, and those were described in the 90s, again by Petrikov and colleagues. But we know that the blood-brain barrier is disrupted in CTE, and we had recently showed that some elevation in vascular injury markers after head impacts and in CTE. We know there's white matter loss in CTE. We looked at this with single nucleus RNA-seq, and we did demonstrate reduced oligodendrocytes. In addition to a reduction in number, there was an alteration in their transcripts. They shifted towards transcripts more relevant to iron metabolism and oxidative stress. And we also know there's increased iron in the CTE tissue. So maybe reflecting, again, that microvascular injury as being essential to the CTE pathobiology. This is a study of 180 football players over the age of 40 with CTE done by Mike Alasko. And again, this accentuates the white matter loss is a key component of CTE. White matter loss is associated with dementia in CTE. And in this study, he was also able to show that changes to the small vessels in the arteriolar sclerosis were associated with dementia, but not years of play. The conclusion here is that dementia in CTE, some of the severe cognitive changes in CTE are tau related. They're also related to white matter. Both of those appear to increase with hits to the head, but it's also related to arteriolar sclerosis. And to date, we have not seen an association between that change and years of play of football. And then this is looking at antemortem white matter flare. This is from a number of brain donors that came into the bank who had antemortem flare. And the most common indication for getting the MR was dementia. And what we found here is that the white matter rarefaction, the volume of these flare lesions was associated with stage of CTE, the amount of tau, the amount of small vessel disease, again, arteriolar sclerosis, as well as what we call white matter rarefaction on pathology. So a way to look at white matter loss in association with CTE that may reflect the severity of the pathology. This is probably our most infamous paper, and I say that because of the controversy that this instilled. But we looked at 202 football players, 111 of them were American NFL players. And we found a shocking prevalence in our brain bank of CTE. This was the notorious 110 of 111 NFL players with CTE. Now, there was no attempt to make this a prevalence study. This was strictly looking at our experience in this case series from our brain bank. This clearly does not represent the general population or even the prevalence in the NFL. This was strictly a brain bank series. But Biney and Bashinsky, about a year after we published that, looked at all the NFL players that had died during that study period. And if you make the assumption that we got all the players that died during that study period with CTE, and that there were no players that died elsewhere that had CTE, then the lowest possible prevalence of CTE amongst this series of NFL players is 9.6%. And that's assuming that we got every single player that had CTE in our brain bank. If you make the much more likely assumption that it was about 10% of the players with CTE or 20% of the CTE players with CTE, then the prevalence amongst NFL players rises considerably to something closer to 70 to 90%. And this is, so we have looked at the dose response between years of play and odds of developing CTE. And this is a study by Jesse Mez, who used very complicated simulation and inverse probability weighting. He accounted for extreme levels of selection bias, and he was able to show that there was a robust dose relationship between number of years of football played and risk for CTE. In fact, the risk for CTE doubles with every 2.6 years of football. And if you play less than 4.5 years, you are 10 times less likely to develop CTE than those who play longer. If you play longer than 14.5 years, 10 times more likely to develop CTE than someone who played less. And last year, Yorgos Strapotis and Jessica Leclerc, biostatisticians at Boston University, they looked again at this. They looked at adjusting for selection bias, and I can't explain the statistical methods; they're beyond me. But the bottom line was that they found that they felt that they found from their data that it appeared that selection bias in our brain bank study actually underestimates the risk for CTE. Now, in community brain banks, since the publication of the NINDS criteria, multiple international groups have looked for the CTE in brain banks, and it's quite rare, running between 0 and 2.2%. In fact, from these 5 studies, I believe there are only very few studies that show, it looks like 21 of the donors had CTE out of something like about 1,800. So that's a very, very small amount. And if you look at those donors that had CTE, in many of these studies, they were exposed to repetitive head impacts, either through contact sports or some other source of TBI, like military service, falls, poorly controlled epilepsy. So not only is CTE rare in a community-based population, when it's found, it's usually in association with some sort of head trauma. So CTE is not unique to American football. It's been described by Lily Hazrati and colleagues in 2019, affecting 55% or 6 of 11 ice hockey players. We know it's in rugby. It's been described by multiple international groups. Rugby in rugby league, CTE in rugby league, as well as rugby union players. It's been described in soccer, both professional and amateur soccer, in young individuals as well as older individuals. And it's been described in military personnel by a number of groups, including the most recent of CTE in the brains of military personnel, described by Premier and Pearl in 2022. As far as the clinical syndromes of CTE, we know it's a behavior, mood, and cognitive change primarily, and for reasons that we don't as yet quite understand, when the disease presents clinically in younger individuals, it tends to be more behavioral alterations and mood changes, depression, agitation, impulsivity, rage. And when it presents in older age, after age 50, it looks much more like a cognitive memory disorder and often appears to be clinically similar to Alzheimer's disease. And we're still trying to understand this sort of duality in presentation. The criteria for TES have been established by now 2 consensus panels for the diagnostic clinical criteria for TES. The TES criteria depend on 3 main features. One is a history of exposure to repetitive head impacts, either from sports, military service, or other causes. There has to be a progressive course of cognitive impairment or neurobehavioral dysregulation, and no other neurologic, psychiatric, or medical condition can be fully responsible for the clinical disorder. Those are the main features of the clinical criteria for TES. And they were evaluated against a series of individuals, 336 brain donors who were evaluated in our brain bank for CTE. And this is another study by Jesse Mez, and he showed that the TES criteria have good sensitivity, but for poor specificity for CTE. They seem to be better at ruling out other pathologies, but have a limited value in ruling in CTE. Now it's the new criteria require cognitive symptoms, and they also require using Alzheimer's disease biomarkers. The point there is if you do an Alzheimer's panel, either blood biomarkers or imaging for amyloid, if you find that the person is amyloid positive, that rules out CTE. So, you know we have a lot of living players. There is a lot of worry about CTE out there. There have been some very crude surveys that about a third of the NFL players are seriously concerned about it. But you do get statements like this from people like Tom Brady, who sort of indicates that his brain is accustomed to the hits and wired for contact, and he may not be susceptible to the injury. And then we have the comment yesterday by Gary Bettman that there's no documented study that suggests that elements of our game result in CTE. And even though there have been isolated cases described, that doesn't mean that the CTE came from playing in the NHL. So who's at risk? I just want to make sure I'm not going over time. Hundreds of thousands of people worldwide. And if you consider soccer and rugby, you know, the major worldwide sports, it's millions of people. What do we need to do? We need to detect CTE in the living. This is the holy grail of all research. It's the rate limiting step. We can't diagnose it with certainty in the living, and that hinders our ability to develop therapies. There are anti-tau therapies. They're being used in clinical trials in Alzheimer's disease and other tauopathies like PSP, but we can't use them in CTE because we don't have a biomarker that we could follow. We clearly need more prevention, safer practices, better care of acute head injuries. We need to reduce the number of head impacts that contact sport players experience. One of the ways of doing that is to start playing the contact sport at a later age, keeping head injury, head impacts out of the youth sports. I think we need to actively monitor players' health, that we are picking up white matter changes to the blood-brain barrier, functional changes in neuropsychs, as well as functional MRI. We are picking that up in living players in a variety of different sports. I think we need to use that more broadly. I know it's expensive, but there's no going back once you lose your brain health. We are starting to identify genetic susceptibility factors. We know ApoE4 is a risk factor for severity in CTE, but not CTE status. We really need to understand the female brain and its susceptibilities. We know it's more susceptible to concussion. It takes longer to recover from concussion, but we don't know much about the female brain and CTE. It's been described in a handful of women, but not enough to really make any broad determinations. And clearly we need to develop therapies and treatments. These are some of the biomarker candidates for fluid biomarkers like in plasma. If we follow the course of what we're doing in Alzheimer's disease, having fluid biomarkers in Alzheimer's disease and having PET amyloid has dramatically changed our ability to treat and follow Alzheimer's disease, and we're hoping to replicate that in CTE. We're looking at differential ratios of different tau phosphorylation species. There's some early suggestion that tau 202 to 396 ratio is more specific for CTE, but we're looking at, many groups are looking at other markers of brain health. We're looking at tau PET. Right now, we're using a tau PET marker primarily called fluorotaucipir, although others are coming along. In most instances, this tau ligand is better for Alzheimer's tau. It was never designed for CTE tau, which we know is different, and we know is 4R tau in the beginning. So there are going to be clear differences in the ability to detect the tau. When we use fluorotaucipir in CTE, and this is a series from our group where we had 6 who had fluorotaucipir and then went on to autopsy, it looked like it might be useful in high stage CTE, but it was not detecting low stage CTE, and whether or not it's specific for CTE looks uncertain. So just to summarize, fluorotaucipir has inconclusive results in CTE, especially early CTE. Amyloid PET is useful to rule out AD in suspected CTE patients. I think I said that wrong earlier, so it's to rule out AD. MRI can be useful. You can see some structural changes. Of course, they're not specific for CTE, but we do see them in a high number of brain donors. Atrophy, frontal insular and anterior temporal lobe, thalamus atrophy. I would say dilatation of the third ventricle with concave configuration of the third ventricle is also fairly specific for CTE, at least in my experience at pathology. Corpus callosum thinning is seen in CTE. It can be very striking. And also that cavum septum pellucidum, which we see in a very high percentage of CTE individuals. And then again, the FLAIR MRI with the white matter hyperintensities. So just to finish up, CTE is a unique tauopathy. It's characterized by a distinctive perivascular lesion of tau, hyperphosphorylated tau, and that tau has a unique fibrillar structure. Since the publication of the NINDS-NIBIB criteria for the pathologic diagnosis of CTE, multiple international studies have reported CTE in case series of sports players, including football, ice hockey, rugby, and soccer. In community populations and unselected brain banks, CTE is rare to absent. And even when found, most of those cases have exposure to trauma. In the ones that don't have a history of exposure to trauma, it's not that we have evidence that they didn't have trauma, it's just we don't have the information. So the ones that didn't have trauma, we just didn't know whether or not they did or not. It's not that they didn't have trauma. So it might be that CTE is exceptionally rare, if it happens at all, in the absence of trauma to the head. The location of the tau pathology reflects the mechanics of the impact injury. It's deposited in areas of greatest tissue distortion and strain. In addition to the tau pathology, very importantly, there's inflammation, microvascular disruption, and white matter loss. Those changes occur early. We see them in individuals who have exposure to RHI but don't have CTE, and I suspect they are important in the pathogenesis of CTE. We also don't know how much they contributed to clinical symptoms. How much does that inflammatory response, the microvascular breach of the blood-brain barrier, even the white matter loss, how much do those contribute to those early changes of behavior and mood, those symptoms that we don't find relate to the tau pathology. So there's a lot of work to be done in terms of that clinical pathologic correlation. We do find there's a robust dose relationship between years of football and CTE, even accounting for the extreme selection bias of brain bank series. The clinical condition associated with CTE pathology is called TES, or traumatic encephalopathy syndrome. And we're very optimistic that in the next 5 to 10 years, fluid and imaging biomarkers can be specifically developed to help diagnose CTE during life. I want to thank all my funding sources, the VA, NIH, as well as private foundations, historically the WWE, the NFL, and NOXI. I want to thank all the families and the brain donors that contributed to this work. And of course, my huge team, because this work takes a village, and we all are very dedicated, hardworking individuals, and I'm very grateful to all of them. And I want to thank you. So thank you very much.
Thank you, Anne. And we have a few minutes for questions. If anybody in the room has a question. John.
Hi, thanks, Dr. McKee. You've made a very compelling argument of the associations and even the causative factors, and yet, notwithstanding political and conflict of interest, there are academics like you who are detractors. Do you find any of the arguments, the counter arguments, persuasive? In other words, for example, having the pathology doesn't lead to the clinical correlation in many, if not a huge or a large number of people. Secondly, that while trauma is necessary, it's not sufficient. There have to be cofactors with it. Again, do you find any of the contravening arguments persuasive in any way?
Well, actually, I don't. I think the reason we don't have good clinical pathologic correlation is that, and admittedly, many of these studies are coming from our center. We just don't have the granularity of the evaluation. Almost all of our studies are done with retrospective informant review, expecting the next of kin to tell us about the symptoms. And I don't think, and we don't have neuropsych evaluations. We don't have a in-person physical exam, and so we're very limited in how much we understand these symptoms. The symptoms are non-specific, and there's no question that many mental health disorders, anxiety, depression are similar to the early symptoms of CTE. But I think that once we have a better chance of looking at the patient themselves and doing longitudinal perspective studies, that we will be able to come up with clinical pathologic correlates. And as I said, I don't think tau pathology is the only factor here. There's a number of brain changes, even in these young individuals. There's macroscopic changes of atrophy, ventricular enlargement, cavum septum, as well as microscopic changes that I think once we have a better granular description and quantitation of their clinical symptoms, we will find a correlation. So that's what I say about where that science is. In terms of cofactors, I think there's overwhelming evidence that trauma is essential to the development of CTE. I'm not convinced by any studies. I don't think there's any convincing evidence for steroid use, drug use, alcohol use, testosterone injections, plastic playing fields, other exposures. I don't think any of those in and of themselves will lead to CTE. I think there is a question whether or not they can increase the pathology, increase the risk for CTE, whether there are additional factors that make you more or less susceptible. Just like vascular risk factors add to susceptibility for Alzheimer's disease. I think we're going to find some of those in CTE, but I think trauma is the single essential risk factor.
Thank you. Charles has a question.
Dr. McKee, that was a fantastic lecture and a great answer to Dr. John Rizos's question. I would like to ask you sort of a future question. Do you think that some of this pathology is reversible? Like, we're hoping that we will see better drugs developed to get tau or A-beta out of the brain. Do you think there's a possibility that we would see that happen?
Well, we've seen with Alzheimer's disease that, lecanemab and things are bringing down the amyloid, and actually they're even seeing lowering of the tau, at least in the plasma, in response to some of these A-beta modified treatments. So I'm very optimistic that some of the tau antisense vaccines would lower our tau load. That said, there's a big part of me that thinks the horses are out of the barn by the time we get tau. I really think we need to concentrate on this vascular permeability, the loss of the blood-brain barrier, the release of cytokines and other inflammatory molecules into the brain, and this inflammatory response, which I think occurs quite early on. We don't have any great anti-inflammatory modifications that I'm aware of, and we don't have any great vascular sealants that I know of, but I'm optimistic that if we could attack both of those things, we would dramatically lower the incidence of CTE, as well as improve the clinical symptoms and maybe prevent CTE in some individuals. I know that's a lot of speculation, but that's what I think.
That's a lovely, optimistic answer. Thank you.
Thanks. And we have one question from the virtual audience who says, very informative talk. Thank you. Although many factors likely lead to CTE lesion pathology, would you say that tau accumulation is a primary factor, which you've kind of answered? The other one is, any idea, guesses on how quickly CTE lesions develop after tau accumulation begins?
Well, those are great questions, and I don't know. We know in animals, it's after a couple of weeks. In rodents, we do see tau pathology in some of these trauma models. I suspect it's probably fairly soon after the impacts too, but I'm not sure that initially it can't be reversed. Tau is on the microtubule; it falls off the microtubule as it accumulates in the cell, but I'm not sure that the cell can't at least originally clear that tau, and actually it's more of a dynamic situation, at least early on. I think over time, the tau begins to accumulate to the point where it's actually causing the cells to dysfunction and die, and that's irreversible. But I'm hopeful that in these early stages, it could be reversible. And I can't remember anything else that I was supposed to talk about. So anyway.
Oh. Well, I think that answers it. And thank you so much for your excellent talk. We so much appreciate and hope we will be able to work more collaboratively in the future.
Absolutely. I'd love that. That would be fantastic.